An 85-year-old woman is newly drowsy, withdrawn, and slow to respond. She is disoriented to time and place, but she is not agitated. She is in hospital due to a recent hip fracture following a fall at home. She is awaiting a hip replacement in the morning. She has type 2 diabetes, hypertension, and mild cognitive impairment. Her temperature is 36.5 degrees, her heart rate is 75 beats per minute, and blood pressure is 134/86. On her bloods, her sodium is 130 millimoles. Which is the most appropriate next step in her management? A. Prescribe haloperidol. B. Perform an urgent CT head. C. Optimize hydration and reorientation strategies. D. Cancel the surgery tomorrow. E. Start IV antibiotics for suspected sepsis. I'll give you about 30 seconds to read and decide your answer. If you need longer, pause the webinar. The correct answer is C. Optimize hydration and reorientation strategies. The question required you to decipher that this patient has hypoactive delirium, a common but overlooked presentation of acute confusion. It is characterized by drowsiness, withdrawal, decreased alertness, and poor oral intake rather than agitation. The most appropriate management includes reorientation, that's reminding her of the time, place, involving family, ensuring glasses and hearing aids are used, hydration and electrolyte correction. Her mild hyponatremia may also be contributing to confusion, and pain control and early mobilization. We'll be going through delirium in more detail in the next slides. The correct answer is C. Optimize hydration and reorientation strategies. The question required you to decipher that this patient has hypoactive delirium, a common but overlooked presentation of acute confusion. It is characterized by drowsiness, withdrawal, decreased alertness, and poor oral intake rather than agitation. The most appropriate management includes reorientation, that's reminding her of the time, place, involving family, ensuring glasses and hearing aids are used, hydration and electrolyte correction. Her mild hyponatremia may also be contributing to confusion, and pain control and early mobilization. We'll be going through delirium in more detail in the next slides. Delirium should be suspected in a patient with a sudden change in behaviour. Delirium is typically acute onset and fluctuates throughout the course of the day. There is often an identifiable precipitating cause. Typical symptoms include abnormal consciousness, so this can present as reduced levels of awareness, drowsiness, or hyperactive. Abnormal cognition, such as memory loss, disorientation, poor language, poor speech. Abnormal thinking, such as distractible and inattention, this means unable to follow commands, poor flow of ideas, disorganized speech. Abnormal perception, such as visual or auditory hallucinations. Other features can include labile change in mood, agitation, sleep cycle disturbances, and hypersensitivity to light and sound. Risk factors for delirium include their background cognitive status, if they had any cognitive impairments, medications including anticholinergics and sedatives, comorbidities such as stroke, dementia, infection, dehydration, pain, substance use such as alcohol and drug intoxication or withdrawal, and environmental such as intensive care stays, sleep deprivation or restraints. Assessment of delirium. It's important to gather a good collateral history from a relative or carer to determine any change in the patient's behaviour over time. Cognitive screening tools can be used to help assessment. A common screening tool is the 4AT, which considers alertness, the 4 AMT questions, asking the patient their age, date of birth, place, current year, the patient's attention, where they're asked to list the months in reverse order, and then the acute change or fluctuating course of the patient's history. For investigations, bedside investigations would include observations, ECG, and a blood glucose. Blood tests would also be important to establish full blood count, inflammatory markers, and imaging could also be used, including chest x-rays, CT heads if you're concerned about an intracerebral pathology such as a subdural hemorrhage, or VBGs or neuroimaging dependent on the history of the patient. Management of delirium. It's important to identify the underlying cause, whether this is infection, metabolic imbalances, medication, pain, hypoxia, and treat as accordingly. Non-pharmacological strategies are first line. It's important to reorientate and reassure the patient, promote sleep, encourage hydration, mobilization, and avoid restraints. Use de-escalation techniques instead. Make sure the patient has their glasses and hearing aids. As per NICE, pharmacological treatments are last resort. Haloperidol is first line, but this needs to be avoided in Parkinson's and Lewy body dementia. Lorazepam is second line, but only if agitation is severe. An MDT approach is important with all delirium patients.